Hello everyone, it's Nick's ASMR, and today we're going to be playing Full Code Medical Simulator. I've got a case loaded up, but before we do so, make sure that you are subscribed, you've hit like, and leave a comment down below. Let me know what your medical experience is. If you're a doctor, tell me what I've done wrong. This is a really cool medical simulation created by doctors for medical professionals. I've seen this on YouTube being used by med students and current doctors to keep up their practice. I, of course, am not a doctor, not a nurse, not an EMT, not a medical professional of any kind, so don't take anything in this video as medical advice. However, I do have a decently wide breadth of medical knowledge from lots of Grey's Anatomy, doing search and rescue, and all the first aid and wilderness response stuff that I learned through that. Watching videos and playing lots of this game. I've probably done 10, 12 cases so far, a couple of them multiple times, so I'm starting to get a feel for it. But without further ado, let's jump into this case. The patient was brought in by a friend to the emergency department, is a 22-year-old male, plus ETOH, found by a friend confused. So he's been drinking, might have a head injury, GCS of 14 by the triage nurse and no other ingestions by report. So a GCS is the Glasgow consciousness scale, and it's a scale of 1 or 0 to 15, 15 being the most mentally ill, so like I'm a 15 right now. And it has to do with if you can open your eyes and what level of stimulant they respond to, like whether it has to be severe pain or if I can just be like, hey man, open your eyes, and you do. There's motor skill in there somewhere, and then like cognitive, I think verbal function. Anyway, that's the GCS, so 14 is not horrible, and no other ingestions. Before I click begin, if the patient is unstable or starts to become unstable, I'm going to have to go through some things to get him stabilized before we can slow down the pace again, and explain more of what's going on. But without further ado, let's jump into this case. Yes, thank you, attending. So we have Eric, a 22-year-old male brought in by a friend with confusion at a New Year's Eve, but we'll call it 4th of July. At a 4th of July party consuming alcohol. No other substances are reported. That's good. The patient was noted to come back to the party briefly confused after going to the bathroom. His friend noticed he was bleeding from the right scalp. Let's take a look at that visually. I don't see anything, at least currently. He declined a medical evaluation and looked okay for about 15 minutes, but became more confused as the friend brought him in for the laceration. He now notes the patient to be even more confused on arrival. So it's clearly getting worse. No allergies, no medical history, no idea about family history. And they drink pretty frequently. This is the worst they've seen him. So it may not only be because of the alcohol, and it looks like he's losing consciousness. So we're going to do airway breathing and circulation exams real quick. Intermittent coughing, he's not protecting his airway. Transmitted upper airway sounds. Symmetric breath, that's good. 2 peripheral pulses. Nurse suctioned out some secretions. He's not protecting his airway. Okay. Now we're going to do a disability check. Pupils non-reactive, patient with just a pain only. So we're going to hook him up to the IV and monitor. 47 heart rate, so he's bradycardic and hypertensive, 175 high blood pressure. So let's prepare to intubate. He's not protecting his airway, so we're going to position Eric for intubation. Prepare the endotracheal tube, suction, and pre-oxygenate. And then we are also going to, we're going to give him an induction agent as well as a paralytic. Rocuronium bolus given. Okay, phenomenal. So we can go ahead and intubate the patient. Okay, so the patient is now intubated. We're going to put a second large bore IV in case we need any more access. And I'm going to put some fentanyl for the pain, and hopefully that'll bring down his intracranial pressure as well. The fent helped his BP out a little bit. Now I'm going to go over our differential of possible diagnoses. So obviously we have an unknown trauma, significant head trauma, number of intracranial injuries, could be hemorrhaging, a TBI. Let's go to neuro. Oh, yeah, I can type things in. Let's go for an intracranial hemorrhage. Yeah, okay, that's it. I just don't know medical terms. It's okay. Gonna look out for. Let's go. Pretty general, but he could have just a closed head injury, a concussion. Gotta look at, he could have an epidural hematoma, and then we could also be looking at other significant injuries that might not come to mind. Intra-abdominal injuries, intrathoracic, I'm gonna go ahead, hemothorax, liver laceration. Gotta look at injuries to the spinal cord. Basically just a broad range of differentials, possible diagnoses, since the patient's an unresponsive trauma patient and we don't really have a good story about what happened. We got liver lac, pelvic fracture. Let's also do a hint. Let's see. Hold on. We forgot to finish the exam. Okay, the hematoma on his right parietal scalp. Let's do a neck exam. We'll do cardiopulmonary, abdominal, clear, no restrictions, non-distended abdomen. Perform a back and flank exam. Musculoskeletal skin and neuro, no clubbing, cyanosis, or edema. He has a scalp laceration, skin's warm and dry, no rashes, and of course he's intubated. No need to run neuro, that was funny. So we don't want to rule out a spinal cord injury. I could have a subdural hematoma, retroperitoneal hemorrhage. I think that's probably about good on the differentials for now. I'm going to briefly click on each of the information bubbles. So if you would like to, you can pause the video and read more about some of these potential diagnoses. I don't think his breathing is labored enough for a hemothorax, but I'm not going to rule it out just yet. No pneumothorax, though, which is definitely good. All right, so now we have our initial differentials. The patient is somewhat stabilized, still a low heart rate, BPU still high, but it is down a little bit. But I'm now comfortable we can investigate a little bit further. So we're going to run some tests. I'm going to start with a finger stick blood sugar, just to get a baseline glucose reading, see if that could be causing any of his issues. And it is not. And that seems super random, but from what I've gathered, really, like a diabetic, a finger stick blood sugar takes all of, 10, 15 seconds, so it's easily testable. So you can just kind of do it real quick, I guess, because it doesn't seem that important. Like, you're like, why are you doing that first? Well, some nurse just did that. So let's do a fast ultrasound. Now stripe in the bilateral upper quadrants, pericardial effusion or fluid behind the bladder. So all that looks good. So let's do our standard blood work. Prepare him for a transfusion if he needs surgery, a blood transfusion, or just basic blood tests. They can also tell us things like if there's any other bleeding or anything going on. So let's run a Chem 7, a CBC. Let's do a coag panel. Did that get added? Yeah. CBC, a blood type and screen. And we'll start there for now, just get some baselines. So our Chem 7, sodium, potassium chloride, bicarb, so everything looks normal there. The CBC, white blood cell count, hematocrit, hemoglobin, and platelets are all within normal range. So the body is probably not currently fighting off any infections or any underlying disease, so that's good. We could be looking at a purely physical injury, which is nice. I've had a lot of really complicated cases with all sorts of stuff going on recently. Coag panel, PT, PTT, and INR are normal, and he's an AB positive. So we're concerned about head trauma. So I'm going to let's order a head and C-spine CT, as well as we'll go chest and abdomen to be safe. So we'll run those real quick. The patient's pupils are now unequal. That's lovely, and his heart rate is falling. So we've got to do something about this dude pretty quickly. Whoa, bingo. There's a massive epidural hematoma, as you can see down there. You don't even, this one's so up, you don't need it. A lot of times when looking at x-rays and stuff, I need the interpretation. Very clear hematoma. And you can see that midline shift as well. Here's where the midline should be, ish. And it's shifted to the right, as you can see. So that's clearly a problem. Our buddy's going to have to go see our friends in the OR, most likely. Normal C-spine alignment, no evidence of fracture. Lungs look normal. No hemothorax. And abdomen. I'm really bad at reading abdomen CT, so I'm going to cheat. Look down here. Normal solid organs, vascular, and soft tissue. Sure, looks normal to me. So pulling up that head CT, that's going to be our main issue here. It's consistent with an epidural hematoma, of course. You can see the large lens shape. This could also cause bleeding in the meningeal artery, which is also not a very good thing. So we're going to need to prep the patient for the OR. To help with the intracranial pressure, we're going to push hypertonic saline solution at 25%. And we don't really know where he fell. He has some lacerations of the head. We'll update his TDAP as well. Yeah, we gotta get him out of here, probably. So we will consult Neuro. Neuro says we'll meet him in the OR. Great. So I definitely feel like I'm forgetting a drug that's related to intubation. I feel like propofol. We're gonna push a propofol infusion for continued sedation. I feel better about that, so let's prep for the OR. I've forgotten that in a couple cases before. And where is it? Oh, epidural hematoma. There we go. So let's hand that off to the surgical team. Oh, would you look at that? Cool, 100%. I guess there's not a whole lot to review. We didn't need to do a cardio or pulmonary exam, but they're recommended. Definitely didn't need to do a circulation exam. Excuse me, it's the second time I've been sick in 2 weeks, so I'm sniffling a little bit. Okay, recommended. The blood sugar, the Chem 7 and spine CT were recommended. We didn't need the CT of the chest or abdomen, probably because it's expensive and takes a whole lot of time. Our primary concern was obviously a brain injury. Should have ordered that first. We would have seen the result. Then again, I'm not sure a doctor in the real world wouldn't not order them to rule it out. I don't know enough about how they would rule out any abdominal injuries or anything, because I hyperfixate. I'm getting better by doing more broad range of tests, but before I'd run one test and see, the glucose high or something, and I would hyper-focus on that. Meanwhile, the patient's crashing because there's a spear in their chest or, something crazy. So yeah, it definitely helps that this is the second time I've recorded this video. I'm not gonna lie. The first recording, my OBS was set up to be really, really zoomed in on the screen, and you couldn't see the whole left or right side, and it was awesome. So that is full code. No idea how we got 100, other than the fact that I don't even know. So this is a great game, great simulation. I've been having a lot of fun with it. There are clearly a heck of a lot of cases for us to work through. So if you see anything that is interesting, let me know. And we can do that scenario. I hope you all have enjoyed this ASMR video. Full code medical simulation. And hopefully our boy Eric does well in recovery in the OR. if you'll do me one solid before we leave and just double check that you're subscribed, you got notifications on, drop a like, a comment. It's free, and truly is one of the best ways you can help support the channel. Let me just brain freeze for a second. Thank you guys so much for watching, and I will see you in the next video.